Hi everybody, welcome to the webinar for Module 5 Week 1. Now, just to remind you again, if you haven't registered for the email notification, you have to get in touch with me. I am putting the emails that I'm sending out up here. But it's easier for me if you get in touch and I add you to the email list. So if you haven't joined that list yet, please just send me an email and I'll send you an invitation to join that list. And then you'll get them in real time rather than having to see them up here. But they're up there just in case you don't see them in your with your emails. So get in touch with me. Now, this week we are going to look at Module 5, Week 1. Let me just have a little look at the topics. We'll get there. Okay. This week we're particularly going to look at some aspects of atopic dermatitis. It's a very common condition, and you know the variation in atopic dermatitis depending on age. And there was a lecture there that I wanted you to have a little look at, latest ideas in managing atopic dermatitis, because you may well get the more difficult cases of atopic dermatitis if you're doing your own skin practice. And that manifestation may be someone with generalized atopic dermatitis, long-standing areas of lichen simplex when they've been rubbing and scratching, who can't get to sleep at night, who are continually requiring short courses of oral steroids to get the skin under control, who are requiring courses of antibiotics. And they're the difficult atopics to manage. They're the ones where you need to consider the use of drugs like methotrexate, azathioprine, and Neoro. Cyclosporin in their management, and also should be considering ultraviolet therapy in the management of those patients. Let's just have a little look in at My Skin Consult at the area of the atopic dermatitis section again. Remember, the major issue of atopic dermatitis is a defect in the barrier function of the skin. They lack the ceramide molecules that normally fill in between the keratin in the surface of the stratum corneum. And so they are much more susceptible to injury, to fluid loss, and to the penetration of antigens into the skin. So it's this loss of barrier function that's the most important feature of atopic dermatitis. Because of that loss of barrier function, the skin is often dry and irritable. So the skin needs to be moisturized. It needs to be protected. And all atopics, irrespective of their age, will need to keep soap use to a minimum, will need to moisturize the skin and protect the skin by having cotton next to the skin, no wool or any other fabrics that are going to irritate it. The level of IgE is often irrelevant. Some patients with severe atopic dermatitis have very high IgEs. Some have relatively normal IgEs but still have very severe atopic dermatitis. So allergy is a factor that can be superimposed on atopic dermatitis. It's not the cause of it. And remember that patients with atopic dermatitis have this lifelong skin sensitivity to irritants. So if they're in occupations such as nurses or hairdressers or in the catering industry, these are people who will suffer from easy irritation of their skin. And so it's often when a mother has a new baby that the hands break down when she's in her 20s, and she may have last had eczema in her very early teens, when the eczema was mainly at the elbows and the knees. But it's when she's a mother and she's getting exposed to excess irritants with a lot of washing and soaping, that's when her hands break down, and she then starts to get an irritant hand dermatitis. The other area in adults that's important is lichen simplex chronicus and prurigo nodules. people rub the skin, and we've seen several examples of this in some of the cases that we've looked at recently, where chronic rubbing of the skin leads to thickening. We saw that case of Nene's tonight with the thickening that occurred on the areola of the breast just with chronic rubbing in someone who had atopic dermatitis. And bilateral areolar eczema is not uncommon in young girls who have atopic dermatitis. There were the conditions that are also more commonly seen in atopics, ichthyosis vulgaris, this particular condition here, pityriasis alba, this condition here, and what was this one? Keratosis pilaris, sorry. You can see the little keratotic papules here and the surrounding erythema in the outer aspects of the arms and often in the thighs. So that's much more common in atopics as well. Bleach baths we talked about before. I think they're of some value. They're mainly in patients who get a lot of secondary infection. And a bleach bath 2 or 3 times a week can reduce the colonization of staphylococci in the body surface. And if there's less of that superantigen from the staph, it can mean that there's less flaring of their eczema. So moisturizing is important when they come out the bleach bath, but bleach baths can be of value in reducing the need for antibiotics. And always remember the possibility of secondary herpes virus infection in atopics, where you've had fairly stable atopic dermatitis and it suddenly becomes painful and irritated. And if you look around, you may see individual little vesicles of herpes. Usually there's little ulcers, more like this particular case here, little punched out ulcers where the herpes virus has been. So it's important that you always look for secondary herpetic infection in an atopic who suddenly becomes worse and their skin is much more tender. Just consider that that condition of Kaposi's herpetiform eruption. What else? There was this particular article here that I wanted you to look at from Mark Dahl and some of the unusual eczemas. It was a good video of that if you had time. I know it takes a little while to go through some of these, but there's a lot of good stuff in that particular video. Now, the big thing that's important at the moment in atopic dermatitis is one of the new cytokine inhibitor type drugs. It's called dupilumab, and it's not yet available in the PBS. We do get it, or I've got it for 2 patients for compassionate reasons. Highly expensive biologic drug. It certainly reduces the itch in patients with atopic dermatitis. And as such, if they're not traumatizing the skin can improve quite significantly. I hope that the drug's given by injection every 2 weeks subcutaneously. I hope that this drug does get on the PBS, but it is expensive. It may well become available for severe atopics, people who otherwise are having their atopic eczema controlled with methotrexate or with Neoral. Neoral is quite an effective drug in atopic dermatitis. It will work 100 milligrams twice daily for most people. But the problem is hypertension and renal issues. And if you have someone on Neoral long enough, they will get kidney problems. So you've got to continuously monitor them, and you've got to try every 3 months or so to see if you can get them off the Neoral or lower the dose and get the minimum dose that you can to control their atopic dermatitis. So dupilumab may well be a major advance in the treatment of atopic dermatitis, but it's highly expensive in the PBS. It hasn't been put on the PBS yet. So, any quick questions on what we've talked there a little bit about with atopic dermatitis? I just wanted to bring you up to date with what's available. The other thing, by the way, that we had in this bit of my Skin Consult, I had some cases there for review in the advanced course. We might just swiftly look at these. I sort of said, answer the questions in your mind before looking at the answers. What do you think of image 1 below? What type of dermatitis is it? How would you treat it? Let me have a look. Anyone want to comment? Nazi, what do you think? Where do you see the dermatitis here?
It's the contact dermatitis from licking.
Yeah,
lips.
I think so. I'd agree. I think that's what that is. It looks like a lip-licking dermatitis. There's a little bit of angular cheilitis there, but you can see that dryness just round the skin there. So if we have a quick look at that case, yeah, this was a 5-year-old girl, rash at the angle of the mouth and some rashes in the lower lip, and lip licking. There was no history of eczema or asthma there. So this was a story. This was a story here. Just the constant licking leads to drying and fissuring, and so that was the diagnosis there. If we look at this particular one, rash on the chin, what other feature is shown by this, and how would you treat both? Have a look at that as well, Nazi. What do you think's shown there? What other features shown?
So there is crust on.
Yeah. So what do you think?
On a red base.
So what does that suggest?
It's a secondary infection.
Yeah, that's right. So how might you handle? What might you use to handle both?
We can use a combination of Bactroban, Advantan.
Yeah, that's fine. That's good. Yeah, that's excellent. Yeah, that should work quite well to treat this. This patient had used a bit of tea tree oil, so you might wonder if let me just have a quick look at the case, and we'll just see what the story was. She had tried tea tree oil, some home remedies. So the diagnosis was infected eczema treated with mupirocin. The Diprazone, I wouldn't have necessarily used Diprazone in that particular case unless it was only for a very short time and the patient understood that. I think mupirocin, a bit of Advantan would have been the better combination to deal with this. A lot of people use tea tree oil because of antibacterial, mild antifungal actions, but you just got to watch the strength of the stuff because it can act as a mild irritant to the skin as well. So the issue here was whether there was a bit of contact dermatitis from the tea tree oil here as well, with a bit of secondary infection. That was good. Now the last one for you, Nazi. Let me go to this. Looking at that, how would you describe that type of eczema on the dorsum of the foot?
I would say it's lichen eczema, maybe a lot of scratching.
Yeah, I agree. That's very lichenified. You can see that the prominent lines and the markings and everything here. So I'd agree it's a lichenified eczema. Why did I say, why is this like? It might be a contact dermatitis rather than a tinea infection. What would be the bit there that would suggest it might be a contact rather than a tinea?
Well, it's unilateral. There is no involvement of web space.
Yeah, I'm surprised it's unilateral. Occasionally, some contact dermatitis, if one shoe is worn down more than the other, you just might get the dermatitis being unilateral. But I agree, the web space isn't really involved there, so it's much more likely to be a dermatitis with secondary lichenification there. Yeah, that was good. Thanks for that. Well done. I'm not sure if we'll have time for all of these, but I just wanted to have a quick look at some of these cases. I might go. Let me just look down a little bit. You might, if you've got time, go. I selected out these cases as various cases of eczema that might be interesting to you, and I've put the links in here to the case in the actual VCM. These were cases that your colleagues have put in over the years on this particular on these particular topics. Let's the red oozy ones are usually some forms of discoid eczema. Let's just have a quick look at that particular case. When you see thick scale and the like this, you're saying to yourself, is this a dermatitis or is it psoriasis? This was an itchy chronic dry rash in the hands. So what's the likeliest diagnosis and management? I would have said some form of irritant dermatitis here. I don't think it's a contact dermatitis. So I would have said, protect from soap, plenty of moisturizers. I would have needed a fairly strong topical steroid, I thought, to maybe get that settled down just now. Let's see what this case was. "25-year-old housewife presented with pruritic lesions on her hands that have worsened over the past 2 years. She reports they're aggravated by bleaches and detergents." So, I've commented there that chronic hand eczema is both allergic and often allergic and irritant factors. I looked at this. Initially, I looked at these hands and wondered about psoriasis because of the Diaz scale and the sharp edges. And I said there's a condition called hyperkeratotic eczema, which some people really think is really just a psoriasis variant. But as I say, a strong topical steroid, good moisturizers, avoid soap, and that will settle. Now look, we don't have time, I think, to go through all the cases there, but you might want to go in and just have a look at these. I mean, it's relatively easy to answer the question that's there and then click and view the case. You might find this interesting just in, just expanding your knowledge of these sorts of cases. There was quite a few. Heavens, I can't remember what that one was. Oh yeah. Oh yeah, this one here. Case 3. Why has this happened after applying black henna? All right. Anyone want to tell me what they think? Why is this all swollen? And I mean, henna is supposed to be a dye that isn't highly allergic. So when I've said this is black henna, what's been happening here? Anyone want to comment? What's sometimes in black henna? Why is it black? What's been added to it? This is when you get these tattoos when you go across to Bali. Raj. Let me unmute you. Can you unmute yourself, Raj? There you go. What do you think's been added to it?
I think it's some kind of this parabenzene kind of thing.
Paraphenylene diamine. Yeah, the dye that's the hair dye. I'm sure you're right. This is what's happened. They add paraphenylene diamine to it to make it darker, and then some people become allergic to it. Look at the swelling. Yeah. Let's just have a quick look at the case. I'll bring up the case.
We have to for them with the topical anesthetic, probably.
Well, I'm not quite sure of what was happening here. Kieran was saying here before, there's no such thing as black henna. PPD, paraphenylene diamine, is added, giving it an ebony color. Ordinary henna isn't black like that. It's usually a sort of browny color, and so the PPD shouldn't be added to these other things. And this is what's happening with these allegedly semi-permanent, not permanent tattoos that you can get in Bali. The problem is that they add a bit of paraphenylene diamine to them, and some people were then becoming allergic to the paraphenylene diamine and could get quite a marked reaction. But this was a lady that had used black henna, and this was the reaction that she got. Look at the blisters. It's amazing the reactions that she in fact got from that. So anyway, there are some nice little cases in there. If you've got time, go in and have a little look at some of these. As I say, I think you might find some of them quite interesting. Okay, let's get back to where we were today. With the clinical cases, I put the wrong reference there. I should have put it in for there. Then dermoscopy made simple this week. We wanted to talk about pseudopods and Reed's nevi. Now, we'll just have a quick little look at that, and then we'll have a look at some of the assessment questions. Pseudopods are a very interesting structure to actually see through the dermatoscope. If you see pseudopods, it usually indicates that you've got very actively growing nests of cells at the periphery of this particular lesion. And active growing cells are nests of cells are sometimes seen at growing nevi. They can be seen at spitz nevi, and they can be seen in the Reed nevus, which is probably just a variant of spitz, and they can be seen in melanomas. Now, with spitz nevi and Reed nevi, the pseudopods are usually all the way around the outside. In other words, they're pretty evenly dispersed around the outside of the cell, or the lesion, I should say. Whereas in melanoma, there's often just a few areas that have the pseudopods, and other areas may just show radial streaking or streaming of lines radial peripheral. So if you see lots of pseudopods and they're symmetrical, it's likely to be benign, either a Reed's or a spitz nevi. If you see just several small isolated areas of pseudopods in a lesion that's also showing a degree of chaos or non-uniformity, then you've got to consider the question of melanoma. So pseudopods are little dots at the end of a stalk, usually connected to the network. Here's a Reed nevus. You can see the symmetrical nature of lots of these pseudopods around the outside. It sometimes can be difficult to to decide between a melanoma and a Reed nevus. And if you've got a very dark lesion like this in the lower leg, almost certainly you'd advise excision of the lesion anyway. So let me just have a look at a couple of other images here. This could easily be a spitz nevus as well as a Reed, but you can see lots of little pseudopods here all the way around this. So it's pretty symmetrical, the pseudopod distribution. Whereas this one, you can see the pseudopods are primarily just in this section here. There are no pseudopods really here. A couple up here again. And you've got, this is an asymmetrical lesion. So when you see something like this, it's unlikely to be a spitz or a Reed's nevus. It's much more likely to be a melanoma. These are actively, rapidly growing nests of cells at the periphery of the lesion. So when it's localized like this with a chaotic lesion, it's much more likely to be a melanoma. Any quick question on pseudopods? As I say, they're a useful thing to recognize, and they're something that should certainly get you thinking whenever you see pseudopods. Okay, let's just back up here. There were these two conditions of Grover's and incontinentia pigmenti that I wanted you to look at, but we've gone over Grover's many times in the past. The other name is transient acantholytic dermatosis, but it's often very persistent acantholytic dermatosis. Incontinentia pigmenti is a rare disorder, usually seen in children, usually seen in females, not seen in males. And it presents as blisters in lines of Blaschko in a neonate, and it'll be a female neonate. And then the blisters change and the lesions dry up and become warty-like, but still have those lines on the distribution along the lines of Blaschko. And later on, the warty areas flatten out and they have hyperpigmentation in the lines of Blaschko. And then very much later in adulthood, the hyperpigmentation disappears and they have areas of hypopigmentation following the lines of Blaschko. So it's a curious sequence of 4 different clinical pictures, starting off from blisters in a neonate and going all the way through to Blaschkoid areas of hypopigmentation in a female later on in life. Let's have just a little quick look at the incontinentia pigmenti in, I think it'll be in DermNet. It's not a condition that you're going to see much, but it's such an interesting condition skin-wise that I really feel you need to know about it. And the other curious thing about the blisters is the cells that they have in them are eosinophils. Lots and lots and lots of eosinophils. So the vesicle is in the epidermis, and the vesicle is full of eosinophils. So the other problems that they can have missing teeth, and they can have some CNS issues later on as well. But the lesions develop in the first few weeks of life in approximately 90% of patients, and the patients are usually females. Don't need to know much about the aspects of the genetics or the mutations or anything like that. It's just that sequence of skin lesions. Look at the blisters that they get at first. And then later on, they get the warty lesions in the same distribution. And later again, they get areas of hyperpigmentation in the same sort of distributions. Again, female. Curious pigmentation along the lines of Blaschko. And later on, it can be the atrophic hypopigmented pattern that they may get. And loss of teeth, delay in eruption of the teeth. Some teeth may be missing. Yep, that's what I always remember. Sometimes they're pegged or cone-shaped. Nails can be involved in up to 40%, ridged, pitted, thickened, completely disfigured. Hair, not really a big issue. Sometimes little areas of loss, little scarring areas of alopecia sometimes in the scalp. Few eye issues, and sometimes epilepsy, seizures in the first few weeks of life might develop too. But I just want you to be aware of those sequence of skin changes. It's a disease that dermatologists love, incontinentia pigmenti, just because of those changes. So you just have to be aware of it, that it's in females, it's in the lines of Blaschko, initially blisters, then verrucous, then hyperpigmentation, then hypopigmentation. Then have a look at their nails, have a look and see if they've got missing teeth or pegged teeth, see if they've had any seizures when they've been younger. And you've got your diagnosis of incontinentia pigmenti. Okay, let's, in the time that we have available, let's just have a quick look at some of these questions. I may do some of them myself. The question there, why is atopic dermatitis becoming more common? And what's the immunological basis for this? In days gone by, we used to tell, if people had a tendency to get atopic dermatitis, we'd say, look, you've got to be breastfed as long as possible, at least up to 1 year or beyond. You don't introduce any solids early, certainly steer well clear of eggs and peanuts and other things that people can develop allergic reactions to. And certainly keep them clean, keep them away from dust mite or animals that they may develop allergic reactions to. But in point of fact, we were doing exactly the wrong thing, because this was setting their immune systems up to become much more unstable, to become much more hypersensitive. And what in fact it was found was that you were much better introducing them to these allergens and dirt and everything else much earlier, because they found that atopic dermatitis was much more likely in the firstborn in a family than it was in the third or fourthborn in the family, who often had to some extent manage for themselves and who were playing with other kids and who were exposed to various allergens much earlier in their life. And so their immune systems developed in a much more healthy way. So we feel that, a lot of the advice that we in fact gave on helping to prevent atopic dermatitis when children were young was in fact wrong. And we encourage them to perhaps have pets and to get exposed to allergens early, so that they're much less likely to develop marked atopic dermatitis. The chemicals associated with itch and the nerve fibers involved. Well, itch is usually an unmyelinated C fiber. So it's a relatively slow, things pass along it relatively slowly. These nerve fibers can grow into the epidermis in areas of skin that are rubbed and scratched. It's the same, the itch and pain fibers can be transmitted along the same nerve fibers. And with itch, it's all not due just to histamine. Prostaglandins are involved with itch. And there are a variety of other chemicals that are involved with itch as well. Now, we did have I did a section, I think, here on sorry, let me go to my Skin Consult, because there was a section I did in there on itch, a module I did in itch. I'm not sure if I put it up here. Sorry, let me just try. There we go. This module 9b, the itching patient. Have a little look in there, and it'll give you some more details on some of the chemicals and the like that are involved in itch, and how itch can occur in a variety of situations, including patients with chronic kidney disease, patients with chronic liver disease, some dialysis patients. Always with chronic itch, you're always looking for scabies in the background. And these were some of the mediators, chemical mediators, that are involved in itch. So it's not just histamine, tryptase, cathepsin S, some of the interleukins, the prostaglandins can be involved. So there's a variety of mediators that are involved in itch. So just giving an antihistamine is often not going to help a lot of patients who suffer from itch. But I think you find this particular section quite useful. So itch is such a common thing. Patients coming in complaining of itch is common. So it might be worth your while at some stage to just have a quick read through this module here on pruritus, both the generalized type of pruritus, pruritus without a skin rash, and localized pruritus like brachioradial pruritus, and maybe read up a little bit about it. So these are some of the other substances down here. The natural opiates, some cytokines, substance P, prostaglandins, as well as histamine, can be involved in the sensation of itch. Okay, let's have a quick look at some of those assessment questions, and then we'll finish up for the night. I have done a video for this, so you can actually go through some of these later if you want. I've gone into some of it in a bit more detail in the video. The disease pattern seen at different ages in atopic dermatitis, that's not uncommon. It's usually in children. It's going to be the truncal areas with some sweat retention and the like first, then it localizes to the elbows and knees as they get a little bit older. Then later on, it's much more lichenified eczema or hand dermatitis that they're going to present with in adult. They'll still sometimes have lesions at the elbows and knees. It's such a common localized area for atopic dermatitis. But the older you get, the more likely your atopic dermatitis is going to be localized to hand dermatitis or areas of lichen simplex and the like. The major systemic therapies used to treat severe atopic dermatitis, we talked a little bit about that earlier on tonight. The methotrexates, the Neoral. I don't like using oral steroids because of the problems that they can induce in the longer term, but occasionally a short course of 50 for 5 days, 25 for 5 days, 12.5 for 5 days, plus some oral antibiotics if there's secondary infection can get them through an acute phase. But in someone who's got long-standing severe atopic dermatitis, that's when you've got to consider the use of methotrexate, the use of Imuran, or the use of Neoral to try and control their skin. And dupilumab, the new biologic, will become available, and I'm sure will make a big difference in the management of these patients who otherwise have to be on these immune modulating drugs. Pseudopods we talked about, seen in Spitz nevi, Reed nevi, but if they're localized, then you've got to consider melanoma. The histological patterns in Grover's, essentially it's acantholysis that you're looking for, split separation of some of the cells in the epidermis, usually just suprabasal, and usually just small localized areas, not a big generalized lot of acantholysis. But you often have to do 2, maybe even 3 biopsies to be able to pick that up, because often you'll just pick up a spongiotic pattern. But that acantholysis is the feature that certainly will allow the pathologist to confidently make a diagnosis of Grover's. And incontinentia pigmentia, I've just gone through the various clinical presentations of that at different stages. So the blistering with eosinophils in the blisters, the hyperkeratotic or warty-like lesions in Blaschko's lines, the hyperpigmentation, and then the mild atrophy and hypopigmentation much later on, with some scalp lesions of perhaps a scaring alopecia and some missing teeth perhaps, and it's females that are going to show that particular condition. So I've gone into the answers to these in more detail there. So if you get time, you can go in and have a little look at that video, and I've given some more pictures and references to those as well. Any quick questions on the topics? I just really wanted to look over atopic dermatitis. As I say, if you've got time, maybe perhaps go back and look at those cases that were in my Skin Consult. It's easy just to click on the link to go back to where the case is in the VCM, so you might find that a useful way of learning some more about the cases of dermatitis as well. I'm just trying to think of various ways that we can help, and that was one way I thought I'd come up with, of just using the cases that students had put up there before, because we've got all the images there and comments are there as well. Any quick questions on anything from tonight, or any other issues that you want to raise? Okay. Look, thanks for attending. Take care, and we'll see you next week.